Welcome to the OMMedicine's module on pulmonary embolisms. Now you need to be familiar with which veins in the lower extremity are considered deep and which are considered superficial, because on your board exam they will commonly ask where the PE originated from, and all of the answer choices will be different names of veins, only one of which will be considered a deep vein. So you need to know that the major deep veins of the lower extremity are the femoral, also called the peroneal, the popliteal vein, and the tibial vein. And remember that the great saphenous vein is actually a superficial vein and not a deep vein. This is a common distractor answer choice on your board exams. So how does a PE commonly present? Well, you'll have dyspnea at rest and on exertion because there's a blood clot in your lungs, so it doesn't matter if you're running or not, you will still have trouble breathing. You'll have hemoptysis. There'll be pleuritic chest pain, and then you can also have the associated signs of a DVT if there's one present, such as calf pain, redness, swelling, and so on. And a PE is a life-threatening condition because of some of the complications that it can cause. So it can cause a lung infarct, or basically a dead piece of the lung because you cannot perfuse it. It can cause a right heart failure, which we'll talk a little bit more about in the next few slides, but this is a major cause of death in patients with a PE, and it can also cause shock, which is usually going to present as an obstructive type of shock, and it's really only going to be seen in patients who have a massive PE or a saddle PE. Now that we've talked about some of the symptoms of a PE, let's talk about the signs, or the items that we can actually observe that are related to a PE. And so you will have four major items that are going to be decreased, and those are going to be your CO2, your O2, which results in hypoxemia, your right ventricular cardiac output, which we'll talk a little bit more about in a minute, and your left ventricular preload, which we'll also talk about in a minute. You will also have some items that are increased, and so your respiratory rate will increase, mostly because you're trying to increase your level of oxygen in the body because it is low, and the way that you can do that is by increasing the respiratory rate. Your pH will go up as well, resulting in a respiratory alkalosis, and that's because you are hyperventilating, and so you're blowing off so much CO2 that your acid levels are going to go down, and that causes an increase in your pH. And finally, your right ventricular pressure is going to increase as well, which we'll talk a little bit about in just a second. Some of the other findings that you may see in a pulmonary embolism is a loud or accentuated P2 heart sound on auscultation, a prominent A wave if you were to look at a jugular venous tracing. You can see sinus tachycardia, which is the most common arrhythmia that you will see in a PE. Do not be confused or tricked by some of the other answer choices. AFib, VFib, VTAC, asystole, all of those are not very common findings in a PE. It is most commonly going to present in sinus tachycardia, so make sure that you're aware of that. And finally, the classic S1, Q3, T3 finding on EKG may be seen, although it is really not all that common in medical practice, but you must know it for your boards. Just need to know that if you do not see this finding, it does not mean that a PE is not present. It just means that if you do see it, it is more likely that it is present. And there's a lot of physiology that goes into all of the information that I just went over. However, the main purpose of this talk is to familiarize you with the findings on labs, on physical exam, and how to diagnose and treat a PE rather than the physiology behind it. Now let's talk about some of the heart changes that occur in a PE, which we were previously alluding to. And it's important to note that the major cause of mortality in a patient with a PE is going to be due to the increased pressure and strain on the right ventricle, which results in right heart failure and then eventually death if not corrected. So if we take a look at the heart and we see that the right atrium is going to pump blood into the right ventricle then pumps it into the lungs and the pulmonary vasculature, and then that blood is going to return to the heart in the left atrium and left ventricle. So what happens in a pulmonary embolism is the blood clot is basically going to increase the pressure in the pulmonary vasculature, and that increases the afterload, or the amount of pressure that the right ventricle has to pump against. Now, if the pressure in the pulmonary vasculature and therefore the afterload on the right ventricle were to increase over a period of years, it would allow the right ventricle enough time to hypertrophy, and that would allow it to compensate by increasing the pressure it can generate, and it would then still be able to pump past the increased pressure in the pulmonary vasculature. However, because a PE typically occurs so suddenly, it is going to increase the pressure in the pulmonary vasculature and therefore the afterload on the right ventricle so suddenly that the right ventricle cannot compensate, and therefore it cannot pump against those increased pressures, and it's going to fail. And what happens is when the right ventricle fails, you now cannot get enough blood into the pulmonary vasculature, and then because of that, you can't get blood to the left side of the heart, and from the left side of the heart, you can't get it to the rest of the body. And so all the blood is going to back up from the right ventricle onwards, so the right atrium, the IVC is going to get enlarged, and eventually you can even have liver enlargement if this continues over a large period of time. And all of the blood that is past the right ventricle, so the pulmonary vasculature, the left atrium, the left ventricle, and the rest of the body is going to be depleted, and you can even go into shock. And this is the reason why having a PE is so deadly, is because it causes right heart strain and right heart failure so acutely that you cannot have enough perfusion to the rest of the body. So if we take a look at the information on our slide, we'll see that the changes in the right ventricle are largely going to be based on time. And if we have a sudden or an acute PE, which most cases of PEs are acute, we will have right ventricular dilation because all of the increased pressure and blood that enters the chamber of the right ventricle is going to push the walls out and make it dilated. Now, it's also important to note that if we were to have chronic PEs, which some patients have, although it's much less likely than an acute PE, you can have enough time for the right ventricle to compensate, in which case it will hypertrophy. This is similar to what happens with the left ventricle in patients who have untreated hypertension. It's a chronic disease until eventually the heart fails. The left ventricle will then be underperfused because we cannot get blood from the right side of the heart to the left side of the heart. And remember, that's all because the PE is going to increase the pressure in the pulmonary vasculature, and the right ventricle cannot pump past that amount of pressure. So we're not getting enough blood to the left side of the heart. In addition, the right heart is going to be so dilated that it's going to push the interventricular septum into the chamber of the left ventricle. That's also going to decrease the chamber size of the left ventricle. And finally, the inferior vena cava is usually going to become engorged, and that's because the right ventricle cannot pump out any blood, and so all of the blood is going to back up into the right atrium, and from the right atrium it will back up into the inferior vena cava, and then the inferior vena cava will become engorged or enlarged because it has to accommodate all of the blood that's backing up. Now let's talk about some of the risk factors for a PE, and it's important to know these because many of your board questions are going to include these risk factors in the stem as a way to help you realize that maybe their dyspnea or shortness of breath is going to be due to a PE rather than some other cause. And all of the risk factors for a PE are related to Virchow's triad, which, if you don't remember, is venous stasis, endothelial injury, and a hypercoagulable state. So supplemental estrogen use, usually in the form of oral contraception pills, is going to cause a hypercoagulable state, and this commonly presents in young women who smoke, because when you smoke you are also causing endothelial injury, and so now you have 2 of the 3 in Virchow's triad, which really causes an increased risk for a PE. Malignancy and pregnancy, or a recent pregnancy, will both increase your risk for PE because they are both considered to be a hypercoagulable state. A recent surgery also causes an increased risk of PE because you're typically immobile for some period of time, which is venous stasis. You've also had a patient been cut into, which causes endothelial injury, and then because of all of the stress to the body, it's also considered a hypercoagulable state. So you've met all 3 of Virchow's triad, and therefore you're at a very increased risk for a PE. And finally, prolonged immobility, such as those who have been on a long international flight or truck drivers who are sitting down and not moving for long periods of time, will have an increased risk of PE due to venous stasis. And the ones that we've listed are not the only risk factors for PE, but these are really the most common ones and the ones you'll see on your boards most often. Now let's talk about the modified Wells score, which is a scoring system that's used to assess whether a patient is likely or unlikely to have a PE. And as you'll see on the next slide, this is going to be very important in driving our decision making about what tests we need to order in a patient who may have a PE. So there are 3 levels of history and physical findings, and they are all assigned a different level of points, whether that is 3 points, 1.5 points, or 1 point. So the history and physical findings that will give us 3 points are if the patient has signs and symptoms of a DVT, so if they have lower extremity swelling or erythema, that would give them 3 points. And then if the PE is the most likely suspected diagnosis in this patient based on your clinical judgment as the physician, that would also be awarded 3 points. If a patient is tachycardic, meaning that they have a heart rate over 100 beats per minute, if they have a history of prior PE or DVTs, or if they've been immobilized for 3+ days, or have had surgery within the past month, then they would all be awarded 1.5 points for each of those criteria. And finally, if the patient has hemoptysis, meaning that they are spitting up blood, or they have a history of malignancy, then those would each be awarded 1 point. So how do we interpret all of the points that we've just assigned to our patient? Well, if a patient has a score greater than 4, then it means that a PE is likely. And then if a patient has a score of 4 or less, then it means that a PE is unlikely. So for those of you taking your board exams, it's important to look for all of these different features in your STEM so that you can calculate a Wells score and then determine whether PE is likely or unlikely. Now let's go through our algorithm for diagnosing and treating someone with a suspected PE. And the first step in doing this is recognizing whether the patient is stable or unstable. So unstable patients are going to be hypotensive, they'll be tachycardic, they'll be tachypnic, and the priority in these patients is to stabilize them first. So give them supportive fluids, pressors if they need it, and then we will want to get a transthoracic echo. And the reason for this is because it can be easily done at bedside, and you don't have to worry about taking an unstable patient to the CT scanner where they may desat or they may go into shock, and then it becomes a big problem. So if our patient is stable, we then need to go through and calculate our Wells score, which we just talked about. And if they have a Wells score less than 4, meaning that a PE is less likely to be the diagnosis, then we will want to order a D-dimer. And we'll talk a little bit more about the role of D-dimers on the next slide, but if the D-dimer is negative, then you have essentially ruled out PE as the cause, and you need to explore other diagnoses. Now, if our D-dimer is elevated, then our suspicion for PE should increase, and the next best step would be to order a CTA. So if our Wells score is greater than 4, meaning that there is a high likelihood of PE, or if the Wells score was less than 4 but they had an elevated D-dimer, we will want to order a CTA of the chest. And so from here we can then identify directly whether a PE is present or not. So if you order a CTA and there's no PE seen, then it's very unlikely that PE is going to be your diagnosis. So you can consider ordering a lower extremity ultrasound, and if that's positive, then you will treat the DVT. If that's negative, then you need to find another reason that the patient is having their symptoms or why they have an elevated D-dimer. Now, if you order a CTA and a PE is seen, you need to make sure that the patient's stable. So you will do all of these supportive measures like supplemental oxygen, fluid, and so on. And from there, we now need to evaluate whether the patient can receive anticoagulation. So if a patient does have contraindications to receiving anticoagulation, such as a hemorrhagic stroke, an active bleed, recent surgery, then they obviously cannot receive anticoagulation, and the best thing that you can do for them is to... Now, if the patient does not have any contraindications to anticoagulation, we now need to evaluate whether they have signs of right heart strain or shock. And remember that right heart strain and failure is going to be the major cause of death in patients with a PE. And the acute increase of afterload to the right ventricle is what causes it to fail. And this is a very concerning finding in a patient with a PE, and therefore it's going to be treated a little bit differently than patients without right-sided heart failure. So if you're evaluating the patient and they have signs of right heart failure, such as distended neck veins, hepatomegaly, splenomegaly, then you want to treat them with anticoagulation plus thrombolysis. And the major indication for thrombolysis in patients with PE is going to be right-sided heart failure. That's very important to remember. Now, one caveat to this whole algorithm is that when you're calculating your Wells score, if you calculate a score greater than 6, you can start empiric anticoagulation before any diagnostic testing, such as a CTA, is performed. And this is because the probability of a PE is so likely that you do not want to delay treatment. Now let's look a little bit closer at the role of using a D-dimer in the diagnosis of DVT and PE. And the D-dimer is a test that has a high sensitivity but low specificity. So let's take a look at what I mean by that. So if we order a D-dimer and it comes back positive or elevated, then it tells us that a PE may be present, but it could also be one of 100 other conditions where there's a blood clot in the body. So it's not very specific for just a PE. Now if we order a D-dimer and it is negative, then it is very, very, very unlikely that the patient has a PE, because that really indicates that there's no clot being broken down, and a PE is obviously a blood clot in the lungs. So to summarize those two very high yield points is if a D-dimer is negative, it's very unlikely to be a PE. But if the D-dimer is positive, it may be a PE, but it could also be one of many other conditions in which a blood clot is present. So this fourth bullet point is very high yield. The role of the D-dimer is to exclude PE as the diagnosis, not confirm PE as the diagnosis, and that's because the importance of the D-dimer is largely in a negative test, not in a positive test. And one other item that you should be familiar with is that in pregnant patients, a D-dimer is normally going to be somewhat elevated. That's because they are in a hypercoagulable state, so there may be microclots that are constantly being broken down, and therefore a D-dimer will be elevated. So in pregnant patients, D-dimer does not have a lot of value. A lower extremity ultrasound would be a better test to perform in a patient with a suspected PE or DVT. Some additional factors that go into the diagnosis of a PE is that chest x-rays are typically not very useful in the diagnosis of a PE, but there are some classic findings on chest x-ray that your boards want you to be familiar with. The first is Hampton's hump, which is an area of infarcted lung tissue that can be seen on a chest x-ray. The second is the Westermarck sign, which is vessel collapse distal to the PE. Remember that a PE is going to cause blood flow obstruction through a vessel, and so all of the blood past the PE will not be able to reach the vessels, and therefore they will not remain patent, and they will collapse in on themselves, which gives you this characteristic finding on chest x-ray. And you can also see other non-specific findings on chest x-ray, such as atelectasis or effusions, and many times the chest x-ray will even just appear normal, which is why it's not a great test to diagnose a PE. Another test that can be used in the diagnosis of PE is a VQ scan. Now these are really only going to be used when a CT scan cannot be used. So if the patient is pregnant and you can't have the radiation dose, or if there's renal failure and the patient cannot tolerate the contrast needed for a CTA, then you can consider a VQ scan. So now let's talk about the anticoagulation regimen used to treat a patient with a PE. And there are several different drugs that are used, the first of which is low molecular weight heparin. There's fondaparinux, there's unfractionated heparin. Then you have your DOACs, which are oral 10A inhibitors such as Apixaban and Rivaroxaban or Xarelto. You can have the direct thrombin inhibitors such as Dabigatran, and then finally Warfarin is not commonly used all that much anymore for the treatment of PE, but it's still sometimes mentioned. Now, it's important to know what drugs should be used in what scenarios, and the oral 10A inhibitors and the DOACs, such as Apixaban, are going to be the mainstay of treatment for the majority of your patients. They don't require a heparin loading dose, they have a very quick onset of action, and they don't require any blood monitoring, such as checking the PT-INR, as you would need to do with Warfarin. Now, the DOACs are great drugs, but they are not able to be used in every patient population. So if your patient is pregnant, for example, low molecular weight heparin would be the drug of choice because it does not cross the placenta as much as some of the other pharmacologic agents on this slide. If you have a patient with renal failure, meaning they have a creatinine clearance less than 30, you'd want to use unfractionated heparin because this drug is not largely excreted by the kidneys, and therefore the renal dose is much lower than some of the other drugs. And finally, if you use a direct thrombin inhibitor such as Dabigatran, a loading dose of low molecular weight heparin for 5 to 10 days will be needed, and this is why when you compare this class of drugs to the oral 10A inhibitors, they're not as preferred to be used because of all these extra steps that need to be performed. Now let's talk about the actual treatment regimen of a patient with a PE or DVT, and there are 3 stages of treatment: the initiation phase, which lasts up to 1 week, the long-term phase, which is anywhere from 8 days until 3 months, and then the prolonged management phase, which is anything beyond 3 months. And the prolonged management phase is not always needed. That will be a patient-specific course, but the initiation and long-term phase up to 3 months is almost always required in the treatment of a patient with a PE or DVT. And it should always be kept in the back of your mind that if there is a very high suspicion of PE or the patient is unstable, that you should anticoagulate before getting diagnostic testing such as a CT. Now, the actual treatment regimen for a patient with a PE or DVT will vary based on a lot of factors such as insurance, cost, how likely the patient is to follow up after their initial visit. But you can see on this slide some of the major regimens that are used, and Apixaban and Rivaroxaban are really going to be the mainstay of treatment because they are so easy to use and it's easy for the patient to use them also. And remember, both of these are going to be your oral 10A inhibitors. Now, there's no point in me reading verbatim all of the drugs and duration and dosing on this slide. You can do that in your free time, but it's important to note that Apixaban and Rivaroxaban are both going to be the 2 easiest drugs to use in the treatment of DVT and PE, but you should also be aware of some of the other regimens that can be used if these drugs are unavailable. Now, it's also important that we talk about some of the non-pharmacologic therapies that we previously mentioned, such as IVC filters and thrombolysis, and then we also will mention embolectomy. Now, the use of IVC filters is very controversial, with some people believing the risk is not worth the benefit and other people believing that the risk is worth the benefit. Nonetheless, it's important to know that the really only major indication for placing an IVC filter in a patient with a PE or DVT is if they are unable to tolerate anticoagulation or if they have recurrent PEs and DVTs despite being on anticoagulation already. Thrombolysis is another agent that can be used in the treatment of a PE or DVT. The 2 major indications for the use of thrombolysis is if a patient becomes hemodynamically unstable, most commonly due to right heart failure or strain. So if a patient has right heart failure or right heart strain in the setting of a PE, then thrombolysis would be indicated. The other indication is if the patient is having limb ischemia that threatens the loss of the limb in a patient who has a DVT. And finally, embolectomy is the last non-pharmacological agent that we can use to treat a PE. It's not very commonly used in the setting of PE, but it can be used if the patient has contraindications to anticoagulation and thrombolysis, and there's really no other options left for our patient. Then we would consider embolectomy. A few other miscellaneous items we need to be aware of. The first is that a PE is the major cause of type 4 pulmonary hypertension. Remember that in type 4 pulmonary hypertension, it's due to an obstruction, which is most commonly going to be a chronic PE. And remember, that's going to be chronic, not an acute PE, because in an acute PE, the heart and the rest of the body doesn't have any time to make compensatory changes to the obstruction. And so in a chronic PE, we do have enough time to have some sort of compensatory mechanism. And in this case, it's going to be pulmonary hypertension, which may lead to heart failure. The other item that we need to be aware about is that PEs are not very common in the immediate post-operative setting. So if a patient just had surgery and then there's shortness of breath, trouble breathing, dyspnea, things like this, then it's most likely not going to be a PE. It's going to take at least 3 days after the operation for a PE and a clot to form. And both of these items come up on a test from time to time, so it's good to be familiar with these two concepts. And we'll finish our talk about PEs and DVTs by talking about post-thrombotic syndrome, which is a clinical syndrome that can present after a patient has a DVT. So post-thrombotic syndrome will present with changes in the same limb that had the DVT after it has resolved, and so it will have pain, heaviness, swelling, changes in sensation, changes in skin color or ulceration, and this will all be seen weeks to months after the DVT has been resolved. And the treatment for post-thrombotic syndrome is exercise, avoiding immobility, compression stockings, and largely, and one of the most important facts for your board exams is that it is not treated with pharmacological therapy. It is largely going to be treated with just lifestyle modification and exercise. And it's important to be aware of how post-thrombotic syndrome presents because board questions will love to make you think that the patient is having a recurrent DVT or that the original DVT has not resolved when they are just in fact having a post-thrombotic syndrome episode. And that brings us to the end of this video on DVT and PEs.